Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. After everything we have discussed about clean anxiolytics, non-benzo options, and the future of anxiety treatment, there's an obvious question that comes next. If benzodiazepines carry so much risk, when are they still appropriate? The short answer is this. Benzodiazepines are not obsolete, but they are no longer general-purpose anxiety medications. They are precision tools. And like any high-risk tool, they require strict indications, clear boundaries, and an exit strategy from day one. So today, we're going to talk about when benzodiazepines still make sense, when they don't, and how to use them without creating long-term harm. So let's start by correcting a common overcorrection. In response to the opioid crisis, the benzodiazepine backlash, and legitimate concerns about dependence, some clinicians have swung too far in the opposite direction, treating benzos as if they are never appropriate under any circumstance. That position is emotionally understandable, but clinically incomplete. Benzodiazepines are not evil. They are powerful central nervous system depressants with specific evidence-based indications. Problems arise not from their existence, but from how casually and chronically they have been prescribed. So let's be precise. The first scenario where benzodiazepines remain clearly appropriate is acute severe anxiety or panic that is disabling and time-limited. This includes acute panic attacks that do not respond to non-pharmacologic measures, severe situational crisis, or acute stress reactions where rapid symptom control is necessary to restore basic functioning. In these moments, benzodiazepines can interrupt the panic cycle quickly and effectively. They reduce autonomic arousal, muscle tension, and catastrophic escalation in a way few other medications can. The key word here is acute. Short course, low dose, clear stop date. If you prescribe a benzodiazepine in this context without defining the endpoint, you have already lost control of the risk. The second clear indication is catatonia and severe agitation, particularly in inpatient or emergency settings. Here, benzodiazepines are not anxiolytics. They are life-saving interventions. Lorazepam responsiveness is both diagnostic and therapeutic in catatonia. In these cases, avoiding benzodiazepines is not safer. It is negligent. The third indication is alcohol withdrawal. This is non-negotiable. Benzodiazepines remain first-line treatment for alcohol withdrawal because they prevent seizures, delirium tremens, and death. No amount of discomfort with benzos changes that reality. Attempting to manage moderate to severe alcohol withdrawal without benzodiazepines is dangerous. The fourth scenario is short-term bridge therapy. This is where many clinicians get into trouble, not because the idea is wrong, but because execution is sloppy. Benzodiazepines can be appropriate as a temporary bridge while waiting for a longer-acting treatment to take effect, such as SSRI, buspirone, or psychotherapy. The mistake is allowing the bridge to quietly become the destination. A true bridge has a defined duration, usually days to a few weeks, not months. The patient knows it's temporary. The prescriber knows it is temporary. And follow-up is scheduled before the refill question ever arises. If a benzodiazepine is still being prescribed months later because it helps, it is no longer a bridge. It has become maintenance, and that requires a completely different risk-benefit analysis. Another appropriate use is procedural or situational anxiety. This includes short-term use for medical procedures, dental work, MRI claustrophobia, or severe travel anxiety. In these cases, intermittent benzo use can be reasonable and low risk, especially when doses are small and frequency is limited. This is very different from daily or near daily use. Now let's talk about where benzodiazepines are not appropriate, and this is where clarity matters. Benzodiazepines are not appropriate as first-line treatment for chronic generalized anxiety. They do not treat the underlying disorder. They suppress the symptoms while increasing long-term vulnerability. They are not appropriate for trauma-related anxiety or PTSD as maintenance therapy. In fact, they may worsen outcomes by interfering with fear extinction and emotional processing. They are not appropriate for insomnia as a long-term solution. They fragment sleep architecture, impair memory consolidation, and lead to tolerance quickly. And they are especially high risk in older adults, patients with cognitive impairment, those with sleep apnea, and anyone with a history of substance use disorder. Now let's talk about the most important piece. How benzodiazepines are prescribed matters as much as whether they are prescribed. If you're going to use a benzodiazepine, the following principles are non-negotiable. First, always define the indication. Anxiety is not specific enough. Is this panic, acute stress, alcohol withdrawal, procedural anxiety? If you can't name the indication clearly, reconsider the prescription. Second, choose the agent intentionally. Shorter acting agents may reduce next day sedation but can increase rebound anxiety. Longer acting agents reduce interdose withdrawal but accumulate more easily. There is no perfect benzodiazepine, only trade-offs. Third, prescribe the lowest effective dose and the shortest possible duration. Escalation should be the exception, not the norm. Fourth, set expectations explicitly. Patients should know from the start that this is time-limited, why it's time-limited, and what the plan is when it stops. Fifth, never allow automatic refills. Benzodiazepines require active decision-making at every continuation point. And finally, always reassess. If anxiety persists, the answer is not to keep increasing the benzodiazepine. The answer is to reassess diagnosis, comorbidities, sleep, trauma, medical contributors, and treatment alignment. Now, let's address a subtle but critical point. Some patients have been in benzodiazepines for years, sometimes decades. Abrupt discontinuation is not only unethical, it is dangerous. Dependence is a physiologic reality, not a moral failure. In these cases, the goal is not punishment. The goal is safety. Thoughtful, gradual tapering, patient collaboration, and replacement with safer long-term strategies are the standard care. Shaming patients or cutting them off abruptly causes harm. So let's close with the big picture. Benzodiazepines are not obsolete. They are not forbidden. And they are not first line for most anxiety disorders. They are powerful, high-risk tools that belong in specific clinical lanes: acute crisis, catatonia, alcohol withdrawal, short-term bridging, and clearly defined situational use. Used with precision, they can reduce suffering. Used casually, they create it. The future of anxiety treatment is not about banning medications. It is about matching the right tool to the right problem with the right boundaries. And when it comes to benzodiazepines, boundaries are the treatment. Okay, that's a wrap for today. If you found this episode useful, share it with colleagues across disciplines. Thanks for listening. And watch out for other episodes in this series where we will talk about benzo tapering. Until next time.